A very good afternoon and a warm welcome to today's clinic. Today's clinic, as you know, is in collaboration of NITRD, Central TB Division and National Task Force. On behalf of NITRD, it is my privilege to welcome our DDG sir, Dr. R.P. Joshi, the NTP team who is logged in and all the attendees. A very warm welcome again. Introducing the faculty from NITRD, I am Dr. Neeta Singla, Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla, he's consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj, she's a senior pulmonologist at NITRD. Now I request our DDG sir to give his address. DDG sir, we are waiting to hear from you.
1 second, madam. Just. The chat is there. They asked me to unmute.
Sir, we can hear you, sir.
Good morning, madam.
Good morning, sir. Warm welcome, sir.
Thank you, madam. And warm welcome to all the participants. It is really a pleasure to be in this difficult to treat clinic. And today, the topic you have chosen is very apt because rifampicin we use so much as a first line that it is very important that we look at the adverse drug reactions of rifampicin. So I congratulate Dr. Singla and whole team and the faculty who are presenting today on this very, very important initiative.
पहले लैपटॉप जरा दोनों के बाद में ले आना हो सब है।
Okay. Thank you so much, sir. So it's only because of your motivation and encouragement that we selected today's case, which is a drug-sensitive case and having issues with rifampicin. So thank you so much for guiding us always. So today's case is from state of Telangana. Dr. Kavya from ESI Medical College will be presenting the case. Dr. Surendra Reddy, who is the professor and head of the Department of Pulmonology, will be the case expert. State expert for the day is Dr. Suman Lata. She is the state TB epidemiologist at STDC Hyderabad. National expert for the day is Professor Rajendra Prasad sir. Sir needs no introduction. He is been, a teacher of the teachers. Sir is the Vice Chair of National Task Force and is also the Director Medical Education at ERA's Lucknow Medical College. A very warm welcome to today's team and over to Dr. Kavya for her presentation.
Thank you, ma'am. Ma'am, is my screen visible, ma'am?
Not as yet, Dr. Kavya. You have to start screen share. Yeah, we can see it now.
Okay, ma'am. Good afternoon, everyone. I'm Dr. Kavya, second year PG from the Department of Pulmonology, ESIC Medical College Hospital, Hyderabad. First of all, on behalf of my department, let me express my gratitude for giving me such a wonderful opportunity. I am here to present a case of rifampicin-induced acute renal failure, which we had encountered in our hospital recently. In November 2023, a 41-year-old male patient came to our OPD with complaints of cough with sputum expectoration since 4 months, loss of appetite and loss of weight since 4 months, and hemoptysis since 1 week. On history of present illness, the patient was apparently asymptomatic 4 months back, after which he developed cough, which was insidious in onset, gradually progressive, and productive, associated with sputum production, which was whitish in color, occasionally blood-stained, non-foul smelling, moderate quantities. And he also complained of loss of weight. He lost about 12 kilogram in the past 4 months. And he also gave a history of loss of appetite since 4 months. And he presented with complaint of hemoptysis since 1 week, which was frank blood, not associated with any blood clots, about 50 to 100 ml per day in quantity. There was no history of fever, chest pain, shortness of breath, wheeze, cold, abdominal pain, itching, vomiting, diarrhea, or any other systemic symptoms. Coming to the past history of the patient, the same patient was admitted in our hospital in January 2023. At that time, he was diagnosed as sputum positive pulmonary tuberculosis, and he was started on ATT for 4 days, after which he developed fever, hemoptysis, loose stools, bilious vomiting, abdominal pain, and dysentery. So during the hospital stay at that admission, on day 2, the blood reports came as abnormal and liver function test was deranged, and hence anti-tubercular therapy was stopped, and we started SLE regimen, which included streptomycin, levofloxacin, and ethambutol. But on the same day, the evening value of serum creatinine levels was found to be raised to 4.7. And on next day, the serum creatinine values, it went up to 8.8, for which we asked for nephrologist opinion. And nephrologist advised titration of dosage of streptomycin, which was 750 mg once daily dose, to 750 mg once in 48 hours. And ethambutol and levoflox were continued. On day 5, we had to start hemodialysis thrice weekly in view of elevated serum creatinine. At that time, creatinine value was 11. And streptomycin dose was further reduced to 500 mg once in 48 hours from 750 mg once in 48 hours. And by this time, liver function test values came down to normal levels. On day 6, SLE regimen was stopped in view of serum creatinine 9.4, and USG abdomen was done, which suggested of submesenteric lymphadenitis. No other abnormalities were detected. And on day 9, nephrologist advised to restart ATT with full dose of rifampicin and isoniazid in view of reducing serum creatinine values and resolve hepatitis and sepsis, along with pyrazinamide 20 to 30 milligram per kilogram per dose on alternate day after hemodialysis, and ethambutol 20 to 25 milligram per kilogram per dose on alternate day. But from our side, we withheld pyrazinamide and isoniazid, and we initiated only tab rifampicin 450 mg OD and tab ethambutol 600 mg on alternate days after hemodialysis. Serum creatinine was 6.7 and urine output was 550 ml over 24 hours at this point of time. On day 11, we had to again withhold rifampicin in view of serum creatinine 7.5. It started raising again, and serum creatinine was reduced to 5.4 on day 13. And on day 15, levofloxacin 750 mg and ethambutol 650 mg were restarted for the patient. On day 17, serum creatinine came down to 2.3, and on day 24, we started isoniazid, pyrazinamide, and moxifloxacin. Ethambutol was continued, and levofloxacin was stopped. On day 28, serum creatinine value came down to 1.2. So patient was discharged on the day 30th after admission with above mentioned drugs. This was his history in January 2023. At that time, his X-ray was this, which suggested of left upper zone and mid zone in homogeneous opacity, likely consolidation. On CT, there were multiple calcified nodules in bilateral lung fields, multiple thick-walled cavitary lesions in bilateral upper lobes and lower lobes, multiple centrilobular nodules in bilateral lung fields, predominantly left lower lobe, patchy areas of consolidation seen along peribronchovascular distribution right upper lobe. Features suggested of old pulmonary cogs with active infection. Coming back to the past history, the patient also had history of pulmonary tuberculosis 10 years back, but details regarding ATT, whether taken or about the duration, nothing is available with the patient. Personal history, he is on mixed diet, sleep normal, appetite is reduced, normal bowel and bladder habits. He is an ex-alcoholic, he is not a smoker, he is a tobacco chewer. Family history of pulmonary tuberculosis in mother 15 years back. No other significant family history. By occupation, he is a municipality worker. On general examination, patient is conscious, coherent, cooperative, oriented to place, time, and person, thin built and poorly nourished. Pallor was there, no icterus, no cyanosis, no clubbing, no generalized significant lymphadenopathy, no edema. Vitals were stable. On head to toe examination, there was no abnormality. Respiratory system examination. On inspection, chest was found to be elliptical and symmetrical in shape. Trachea appeared to be at center. Apical impulse was appreciated in left fifth intercostal space, 1.5 centimeter medial to mid-clavicular line. There was no use of accessory muscles for respiration, no drooping of shoulders. Clavicles and ribs were found to be little bit prominent. On palpation, all inspection findings were confirmed on palpation. There's no local rise of temperature, no tenderness. Vocal parameters equal in all areas. Bilateral chest movements are equal in all areas. And on percussion, all areas were resonant with a relative cardiac dullness on the left side from second to fifth intercostal spaces. On auscultation, bilateral air entry was there, normal vesicular breath sounds, no added sounds. On CVS, gastrointestinal system examination and CNS revealed no abnormality. This was the latest X-ray of the patient in November 2023 when he presented to us. In X-ray, you can see there are inhomogeneous opacity, left upper zone, left mid zone, which is bad compared to previous X-ray. And right side also, few patchy opacities we can see. And on CT, thick-walled cavity lesions in left upper lobe, superior segment of left lower lobe, multiple ill-defined nodular opacities of varying sizes seen in bilateral lung fields, few of them are calcified, and multiple central lobular nodules seen in bilateral lung fields. So the course in the hospital, patient was diagnosed as sputum positive pulmonary tuberculosis again with rifampicin sensitivity. Chest X-ray and HRCT suggested of multilobar consolidation with multiple cavities. Blood reports were normal, hence patient was started on tab isoniazid 300 mg/OD, pyrazinamide 1250 mg/OD, and ethambutol 800 mg/OD, levofloxacin 750 mg/OD on day 4. And patient developed no adverse effect. On day 6 of admission, serum creatinine was 0.58. And on day 8, the patient was then started on tab rifampicin 600 mg/OD, after which he complained of chills, shortness of breath, and back pain. He was managed with injection Avil, injection hydrocodone, and injection tramadol stat doses. Rifampicin was stopped. And blood reports on the next day, it showed WBC counts 33,991. Blood urea levels were 107.8. Serum creatinine levels were 3.12. Liver enzymes ALP 252, AST 439.9, ALT 89.6, albumin was 2.6, total bilirubin was found to be 15. Physician advice was taken and they advised to start tab UD-LIV 300 mg BD, tab Newsum 400 mg BD. On day 10, USG abdomen and pelvis was done. It suggested of moderate ascites, bilateral grade 2 renal parenchymal changes, altered liver echo texture. And on day 10, serum creatinine became 3.13 and HD catheterization was done. Patient was diagnosed with rifampicin-induced nephrotoxicity and hepatitis, and ATT was stopped. On day 11, the lab report suggested of WBC count 13,750, creatinine 7.3, urea 168, ALP 169, AST 46, and ALT 17. So here we can see a box. In that, on day 11, we can see that creatinine was 7.3. On day 13, it became 10.37. On day 15, 9.17. And day 17, 8.02. Day 20, 4.51. ATT was stopped throughout this time. And on day 20, we started with tab isoniazid 300 mg/OD. No side effects were observed with INH. And on day 22, along with isoniazid, tab ethambutol 600 mg/OD was started. Ophthalmologist opinion was taken to start ethambutol. Patient has normal fundus findings and was given clearance to start ethambutol. No adverse reactions observed with ethambutol and isoniazid. Nephrology opinion was taken in view of need for renal biopsy. They suggested creatinine to be below 5 and advised hemodialysis. On day 25, serum creatinine became 2.19. So we again asked nephrologist opinion. They suggested daily monitoring of RFT and serum electrolytes and bicarbonate. And as acute kidney injury is improving on withdrawal of rifampicin, renal biopsy is not required from their side. And nephrologists suggested to stop hemodialysis and completely stop rifampicin as the acute renal failure was attributed to rifampicin. So tab isoniazid 300 mg, tab ethambutol 400 mg OD, tab levofloxacin 500 mg OD were given and the patient well tolerated the medication. Finally, a diagnosis of rifampicin-induced acute renal failure was made and patient was discharged with tab isoniazid 300 mg OD, tab ethambutol 800 mg OD, tab levofloxacin 750 mg OD for 6 months and tab pyrazinamide 1250 mg OD for 2 months. And patient was advised regular monthly follow-up in the outpatient department. So in the last 1 year, this patient had 2 admissions. At each admission, the patient stayed in the hospital for almost 30 days. And there were many ambiguities which we faced while treating this case. So this leaves to us a question: how should we manage the case of rifampicin-induced acute renal failure? That's it, ma'am. Thank you.
Thank you so much, Dr. Kavya. Very well presented and very exhaustive history, of course. So those of us, you who have joined us after the presentation has started, basically this is a case who was started on ATT about a year back, and patient was was diagnosed as smear positive patient and started on ATT, but patient has a previous history of ATT. And there also that time in January 23 also patient had problems with rifampicin and had renal issues in January 23, but I think he got cured around that time with that treatment and has come back again for the treatment. Patient is rifampicin sensitive, so trial of FDC was given, but on day 10 he again had issues where the creatinine started rising, and there were changes also on ultrasound. So all the ATT was stopped for 10 days, and after 10 days they introduced INH plus ethambutol, and they tried to introduce rifampicin, but then again there were signs of renal injury, and patient was diagnosed as RIF-induced acute renal failure. And patient was later discharged on INH, ethambutol, levoflox, and pyrazinamide. So have I missed anything, Dr. Kavya? Okay. So with that, there must be some queries on the history of this patient. So we open this house for discussion for any questions on history or investigations for this patient or diagnosis. Yeah, so we have some questions on chat. Dr. Saroj will be taking them.
So, does the history mention using oxytocin? When the patient took ATT in 2023 January, was it completed? Was the treatment completed? There's one query in the regarding history. Dr. Kavya?
Madam, instead of behalf of Kavya, I am the professor, madam.
Yeah. Hello, welcome, sir. Dr. Reddy is the head of the department pulmonology. Welcome, sir. Yes, sir.
So,
yeah, good afternoon, ma'am.
Took history in 2023 January also. Was the treatment completed during that time?
Yes, ma'am. What actually ours is that periphery, ours is tertiary care center, ma'am. Actually, these patients will go to their native place, but we don't have documents. What he say when he admitted in November, he told that he completed the 6 months of treatment. So from the January to next November, he did not come to our hospital, ma'am.
Okay. Okay.
And he doesn't have that card also that treatment completed and all. But what he says is that according to him, he completed, ma'am.
Thank you, sir. Thank you, Dr. Reddy.
So there's a query as what is the DST pattern at both times in 23 as well as now when he has come to
Both times Yes, ma'am. Both times sputum positive, rifampicin sensitive, ma'am.
Any liquid culture done, sir? Anything about?
Not done, ma'am. So only CPNet done.
So initially we introduced doses of 600 rifampicin. While what was the weight of the patient when he presented to you?
बंद करो.
The initial weight of the patient was not mentioned in the history.
Not mentioned, ma'am. Around 52, 53 kgs, ma'am.
Okay, but high dose of rifampicin was given to the patient when he was 52 kgs and the rest of the drugs were in low dose. And
Yeah, so the question is why was it given as 600 milligram for a 50 kg patient?
So according to body weight, we calculate, ma'am, 10 mg per kg body weight up. So we can't divide, no, ma'am. So around it will come around 520 milligram. We gave 600 mg.
What's the answer?
शुरू में फर्स्ट क्वेश्चन.
so this to rule out connective tissue profile, whether CN curve, PN curve profile of the patient was done or not. This is a question. And what was the HIV status of the patient?
Ma'am, ANA profile, Priyanka, Siyanka, vasculitis profile not done, ma'am. And HIV status done, ma'am, negative.
It was negative.
So, Dr. Reddy,
Sir.
am I audible?
Yeah, yes, sir, you are audible.
What I have heard, I'm sorry I joined little late because of some issue, but what I have heard that patient is still on treatment, and the last CT and X-ray you have shown it has quite a bilateral disease. So, what is the current status of the patient? How many months of treatment he has already finished, whatever modified regimen you are given, and then what is whether he is responding, not responding?
Yes, sir. So we discharged November last week, sir, around 29th or 30th November. In the month of first week of January, I called to patient. He said that he's doing well, sir. He didn't come. He went to Maharashtra. His relatives are there. He will come this month, and sir, for 2 months, end of the intensive phase, he told that he will come in the next week, mostly 28th or 29th, he will be back, sir.
And what are the drugs in the intensive phase you are giving?
Now we are giving isoniazid, ethambutol, levofloxacin, and pyrazinamide, sir.
Okay. And he is tolerating these drugs as,
Yes, sir.
as a statement of the patient.
Yes, sir.
Dr. Neeta?
Yes, sir.
Dr. Padma had raised her hand.
Sure, Dr. Padma. Welcome, Dr. Ashok Bharadwaj, sir. Sir is the chairperson for the NTF. Welcome, sir. Dr. Padma, yes.
Nita, sorry, the question I had put it in the chat box also. The question was the same thing that I asked earlier too. Like, why did the treating team not think of sending for other resistance pattern, especially the second time? Because if you see the X-ray from the first time what you showed and the second time there seems to be deteriorated, first point. Second, you have done only on expert. What about even H-resistant, leave alone thinking of MDR or other resistance pattern? So the question is, did you even think or you thought facility is not available? I know this is from Kerala, so they should be having culture facility backup.
Thank you, Dr. Padma, for the question, and thank you for joining us. Welcome to our clinic. As everybody knows, Dr. Padma is Director, NIRT Chennai. Welcome, ma'am. Over to you, Dr. Reddy, for the question Madam asked.
Ma'am, good afternoon, ma'am. So honestly speaking, we have not thought of other drugs resistant, ma'am. Only rifampicin sensitive. We restarted ATT. So we didn't send for liquid culture, ma'am.
Dr. Reddy, there is one more question. We started the patient with levofloxacin to begin with. But on day 24, we have changed it to moxifloxacin. Was there any particular reason behind it?
Actually, it was advised by nephrologist. So he read some article and so instead of levo, moxi is much better through. Then we started moxifloxacin, ma'am.
Okay.
Dr. MODTC Ganja has raised his hand.
Good afternoon, ma'am.
Good afternoon.
So, the treatment has been changed from rifampicin and to levofloxacin. So then moxifloxacin. So it's okay, but we should have a second line LPA report regarding the sensitivity of levofloxacin or fluoroquinolone 2 for that. And as it has already been discussed, the response of the patient should also be monitored. What is the end IP result? Initially, the patient is smear positive. Whether there is smear conversion or not, and what is the weight of the patient, whether that is increasing or not. So those things should also be taken into consideration after giving changing the regimen from RIF to Levo or Mox. So
Right.
these two things should be taken care of.
Dr. Reddy, the question is, was the LPA done for this patient?
Not done, ma'am.
Okay.
Though rifampicin sensitive, so actually the guideline is we send the LP report of all MTB detected cases. So ideally, the LP report samples should have been sent, and by the time treatment has started, to have the both first line and second line report.
Okay, sir. Your point is noted, sir.
Dr. Reddy, very nice case presentation. Just small query I'm having. Usually we say rifampicin nephrotoxicity in cases where we give intermittent rifampicin to the patient. That is what's being reported. It's very, very rare when we give daily regimen to the patient. Was there a history of rifampicin withhold, like we withholded the rifampicin after start of the treatment?
Ma'am, pardon, ma'am, I couldn't get your question, ma'am. Can you repeat once again?
Sir, what we had, the literature says that the rifampicin nephrotoxicity is seen in
Yes,
cases where it is when it was given intermittent doses, like when we are giving thrice weekly doses, not on a regular basis. And the toxicity in patients who are taking on a regular basis, on a daily basis, is very rare. So I'm
Yes,
just
ma'am.
asking whether we have withhold the treatment in between. Was there any history in this patient where we have withholded the treatment or we have withholded rifampicin for some time being, and then we have restarted and we noticed this nephrotoxicity? Or it was on a regular, or we are giving the patient was taking regular treatment, we noticed.
No, ma'am. Second time, once we started rifampicin, RFT, LFT deranged, immediately we withhold the treatment, ma'am. Once again we started, just creatinine started rising, then we stopped permanently, ma'am. Withhold.
Sir, we one more thing, like this also is associated with hemolysis, rifampicin-induced hemolysis, commonly seen when it comes with nephrotoxicity.
Yes, ma'am.
So
Yes,
we have
ma'am.
seen the WBC count. So was the hemoglobin stable during the course of the?
Yes, ma'am. There is no hemolytic anemia.
No
Yes, ma'am.
hemolytic.
Hemoglobin is normal, ma'am. Within the normal range, it maintained.
Okay, thank you, sir.
Thank you, sir. Are there any other questions? So, Dr. Sumanlata, we would like to hear your comments on the case. Dr. Sumanlata is a state epidemiologist at STDC Hyderabad. Dr. Sumanlata?
Yes, ma'am. Yeah, ma'am. Can you hear me, ma'am?
Yeah, we can hear you, ma'am.
Yeah. Thank you so much, ma'am. And we had this case, man, like when we have a case where we know we got a diagnosis from either TrueNat or CBNat. And when we start a drug-sensitive TB regimen, and when they are not complying or they are not able to tolerate any of these drugs, so the first thing which we go into the mind is the possibility of the adverse drug reaction and or associated something with it, something like that. And many a times this happens to be that we do not encounter a very normal adverse drug reactions because in this case we did not see a routine or regular adverse drug reactions like hepatotoxicity. Only one initial phase they had a deranged LFT. After that, more of a creatinine levels, almost it was monitored, and there was a de-challenging and re-challenging of rifampicin done in the 2 phases. So where we understood that this serum creatinine levels were deranged, and multiple times a nephrologist opinion was also taken to rule out other possibilities of renal ailments, and to get to the conclusion that this rifampicin, this acute renal failure was happening due to rifampicin. So this is one area where it is a very rare scenario where we haven't heard of. And when we started this SLE regimen, there also we have tapered the dose of streptomycin, and then we started to look into his LFTs and renal function tests. There also we were identifying the streptomycin as an agent, because already the deranged LFTs have stopped us using from rifampicin. So second time when we started with HRZT after LFTs were turned normal, and when we saw our serum creatinine, it was in a very if you mark a graph of the serum creatinine levels against the days he was admitted in the hospital, it was very high, deep, almost reaching to 10.37 at a point. And then when we stopped rifampicin, it was coming down. So it was if you see in the pharmacovigilance part of the this is very certain that this renal failure was due to rifampicin induced renal failure. So these were a few observations which I thought we would bring to in front of many experts who could agree or disagree or can debate on that. So these are few comments from my side.
Should have been ruled out. Yeah, thank you, ma'am. My query is, ma'am, that when we are designing a regime, especially for a patient who has been previously treated and who has had a history of, contact, his mother had TB. So it's like when we are putting this patient on fluoroquinolone resistance, we should have ruled out, fluoroquinolone regime. We should have ruled out the fluoroquinolone resistance. Any comments on that?
Yeah, ma'am. Yeah, that is very honestly speaking, we missed on that part. That is one more take-home message, because we already knew this. He had a contact history, and also he was himself a TB patient a few years ago. So these 2 points should actually prompt us to know the DST of DST status for all the drugs for the first line and also the second line. Yeah, that honestly we missed. We have to.
Sure, ma'am. There's a question. There's a comment from Dr. Padma. Yes, ma'am. Over to you.
Sorry, Dr. Nita. This is question to Dr. Sumalata. Dr. Sumalata, I know NIRT is the NRL attached to your center.
Yes,
I really feel sorry that this patient we somehow missed doing the DST.
Yes,
and it's worse. And I understand managing the adverse event was priority. I totally agree. But is there any other logistic issue, Sumalata, in your lab that you were not able to carry out the DST? I mean, anyway, we can help as an NRL for you.
No, ma'am. No, there was no logistic issue, ma'am. But our liquid culture lab got renovated from April 2023 to now, ma'am. So now, 2 days ago, it's restarted functioning after the renovation, ma'am.
Yeah.
So what? This sorry, doctor. Just one more point, Dr. Neeta. Sorry.
No, most welcome, ma'am.
If you still have this patient with you,
Yes,
I would
ma'am.
request you to send the sample for DST even now. Nothing is wrong if you do it now. If you're still
Yes.
producing sputum and smears are positive, better late than never. Let's do the DST for him and check whether he's still sensitive to the drugs that he's on. Thank you. That was the last thing, Dr. Neeta. Thank you.
Okay, ma'am.
Definitely.
We'll send, ma'am.
Yeah.
Thank you. Are there any queries on the treatment part? Over to Dr. Rajendra Prasad, sir, who is the expert for the day today. Sir, for your comments, please.
As I understand about the case has been treated twice, once before, and is still being treated.
Dr.
And this and it appears by seeing the CT and X-ray, patient has a extensive disease, bilateral disease, more on the left side than this side. And then, as per investigation wise, as everybody is pointing out, as per rule of anti-EP, probably the patient was not thoroughly investigated. That was another comment I have to offer, because these are the things which ultimately lead to development of a drug resistance. The second point, it appears that the case was renal toxicity with rifampicin is a rare, and usually somebody has already pointed that usually it happens. It is a sort of an autoimmune reaction, and it is more seen in the intermittent therapies rather than the daily one. But then I surprised once he developed this renal toxicity, how he is tolerating again. That is another point. One has to be very careful that once a patient develops a renal toxicity, so he may develop again. My third point of advice would be that such type of patient should be admitted for even a longer time, because there are two issues that you don't know about his compliance. You don't know when he is going to develop the drug intolerance, and then whether he will come, he will not come. Those are issues which arise. Because he is a very, very, very important case as far as TB is concerned, in the sense that we should ultimately cure him. To treat tuberculosis with the drug with the drug intolerance, especially the renal drug intolerance, is a difficult issue. So, regular follow-up and maybe more medicine. And I agree with the comments offered by many that ideally the DST pattern should be known. Today we talk of universal DST. Now, this case was treated in 23 onwards. This is a very recent case. And still we have not offered him universal DST. When we say universal DST means we should know that whether there is any isoniazid resistance, there is any other resistance. So as per rule, if you go, you have to do these LPAs and then even culture and sensitivity for every patient, especially in this scenario. This patient has already taken treatment once, and you see the radiological picture. Patient had a very extensive disease. So let us hope, as we know that he is improving. Although from distance we know that he is improved, patient has told. So my suggestion would be he should be very regular follow-up. And you should be ready that if some other drug, rifampicin usually renal toxicity is, as I said, I'll repeat, is not very common, but it appears that it was due to rifampicin resistance, rifampicin intolerance. So that's all.
Thank you so much, sir. Thank you. We have a question from Dr. Shakil Ahmed. Dr. Shakil.
Thank you very much. Professor Shingla, this is Dr. Shakil, Professor Shakil. I'm talking from Dhaka, Bangladesh. So it's really, I enjoy your
welcome.
sessions.
Nice that you have joined.
Okay, thank you very much, sir. So I really enjoy your sessions, and really there are a lot many learning points from here. And the interstitial nephritis that happens in renal toxicity is really a rare thing. But I must thank the presenters to present in toto what they have done for the patient. And from that thing, I think there are a lot many learning things for us. For me as well, that these things, the things that has been deviations that happened, it happens. And from here, I think the audience of 320 plus will learn, we have learned that yes, we must do universal DST specifically in such a case where it has been treated twice with a history of another person having TB in their family or in the community. So that has been missed, that we also we may miss many a times, but probably that's a lesson we must once again reinforce within ourselves. Thank you very much. This is my just brief comment. Thanks, Professor Shingla, once again.
Thank you, Dr. Shakil, for joining. Thank you very much. Now I'll take comments of Dr. Rupak Singla. There are two questions. What are the risk factors for ADRs to develop? And when should we suspect that there is some renal issues happening with the drug?
Thank you. You see, we, as somebody said also, with rifampicin, there are some side effects which are known to occur when we give it intermittently, or we start this after stopping for the duration of few days or whatever it is. And these include the flu-like syndrome, shortness of breath and shock, acute hemolytic anemia, and acute renal failure. So these are the four specific observations which occur only with intermittent rifampicin. And when you give rifampicin, in case patient has to develop the acute renal failure, the acute renal failure due to the interstitial nephritis, the time duration is usually between 12 to 20 hours. It may be a little longer, but there are two case series on this. One is of 60 patients, one is of 25 patients. Then there are individual reports, case reports. So what they found is that the gap between rifampicin being given and developing the acute renal failure is, say, within a day, you can say. Then again, they've also analyzed after how long does it occur. They found that if you have taken rifampicin, say about 1 month to even 1 year back, and now you reintroduce or now you give rifampicin, patient can have the rifampicin-induced acute renal failure. In this case, it is very interesting is that patient had taken HAD 10 years back. We do not know what exactly happened. Then again in January 2022, patient had taken rifampicin containing regimen. And patient had, if you see the chronology, patient had rifampicin-induced acute renal failure. And now for last 4 months, again, he had symptoms and he was put on a regimen containing rifampicin. So he was definitely at high risk for developing nephritis. And it is generally said that if a patient has had rifampicin-induced acute nephritis, it should never be given. Because the risk factor for mortality is in case you introduce rifampicin again after a previous history. So once there is previous history of rifampicin-induced renal failure, it should not be given again. And how these patients you see present? Usually they present with fever, flu-like syndrome. The GI symptoms are very, very common. And if you go to the laboratory, they have anemia, thrombocytopenia, hemolysis, which is usually immune-induced. They can even have the DIC, that is disseminated intravascular coagulation. And of course, they also have about 25 to 30% of cases abnormal or raised liver enzymes. Like in this case also you notice in the first episode also, in the second episode also, the liver enzymes were also raised and of course acute renal failure. So these are the laboratory reports which can happen with rifampicin induced renal failure. Unfortunately, what happens, people who are treating them, they are more bothered about the hepatitis. Like even in this case, the regimen was being modified, which should be modified, is as per the liver enzymes being raised. And then if you see that in this case, why somebody asked why moxi was given, moxifloxacin is safer for kidneys compared to the levofloxacin. So whenever we have the acute renal damage, we should consider moxifloxacin in case we are considering the quinolones. And the drugs like INH, ethambutol, pyrazinamide, they are removed during dialysis. So in case we plan to give them, they should be given after dialysis. Rifampicin is one drug which is not removed by dialysis. So this is just to talk about the drugs in renal failure. And as we know, among the ATT, INH and rifampicin usually do not require any dose modification unless it is severe renal failure. But ethambutol and pyrazinamide, they need the dose adjustment in case of renal failure. Now, once it develops, how to treat it, that's also very important. What the previous studies have shown, the most important treatment modality is hemodialysis, especially when you find the creatinine is too high, say 6, 7, or 8, something like that, and there is anuria, which is common in such cases of acute renal failure. The hemodialysis is the answer, and in most of the times, the prognosis is good. In case you are able to manage the other comorbidities like hepatitis, the hemolytic anemia and all this, then the prognosis is good. And what they found is that usually within a month, patient they recover. And sometimes it can take even up to three months. So one has to be patient in these cases and then see what is happening, but usually the prognosis is good. But as I mentioned earlier, in case we have reintroduced rifampicin in a case who has had acute renal injury after rifampicin, then prognosis becomes poor. So this is one factor which indicate that we should never give rifampicin again if there is a documented or suspected acute renal failure because of the rifampicin. So in these cases, I think the take-home message should be whenever a patient on rifampicin, where it is being given intermittently, or it is being restarted after a few days, and patient develops this kind of symptom like flu-like syndrome, the gastrointestinal symptoms, anemia, abnormal liver enzymes, the hemolytic anemia, thrombocytopenia, we must keep in mind that maybe patient is going towards rifampicin-induced acute renal damage. We should suspect it early, try to manage the hepatitis portion of this, try to manage the renal impairment portion of it, try to manage the hemolytic anemia portion of it, and thrombocytopenia. So we have to have a multidisciplinary approach in the management of such cases. And of course, as everybody discussed regarding the DST pattern, in today's time in India, with the universal DST being in place, we should make all attempts in a case that we have not only the rifampicin resistance, also the INH, also the fluoroquinolone resistance should also be in hand, so that we can design an appropriate regimen for these patients. So I think that's all from my side. Thank you.
Thank you, Dr. Singla.
Thank you. Thank you. May I come in?
Sure, sir. Sure, sir.
Thank you, Rupak, for analyzing very well. And my suggestion also is that this patient has to be followed very strictly by the team, whosoever is treating. I mean, this treat him as a special case. And what we have already taught that once a person develop a rifampicin induced renal failure, then starting rifampicin is it may be very detrimental for the patient. So that is why he needs a very careful, he needs a very careful observation. And for that, even if you have to admit, you have to convince your patient that you have got a major problem, you have got a major adverse drug reaction with the drug. So either you come regularly. So the counseling part is also very important in such type of patient. Not the routine type of counseling these patients will follow. very good counseling every visit whenever it comes. It is required for such type of patients so that they might complete the treatment and they might get cure out of this. Thank you, Rupa.
Thank you so much, sir. Dr. Singla, I have a question that this patient had nephrotoxicity. What if he didn't have nephrotoxicity and if he had hepatitis, we can, get more. How do we manage such patients and what is the replacement sequence in such cases?
You see, again, it's very important. Renal failure by rifampicin is very, very rare. But hepatitis by rifampicin or INH and pyrazinamide is quite common. So through this case, I think we need to discuss about the hepatitis management also. Whenever there is a drug-induced hepatitis, you see, first thing we see is how severe is the hepatitis and whether patient can wait after stopping the drugs for some time, or patient cannot wait. We have to give some treatment during this intervening period. Suppose there is a patient of meningitis, patient of bilateral extensive disease, patient who is smear positive, 3+ positive. In these cases, we won't like to wait till the enzymes come back to normal. We won't like to stop all the medicines. What we do is, in case there is no contraindication, we start with streptomycin, ethambutol, and quinolone, and then wait for the enzymes to come back to near normal. When I say near normal, means maybe around 2 times the normal, and then we start introducing one by one. Usually INH is started in the dose of, depending on the what level of hepatitis it was, say 50 or 100 milligram, and then 200 and 300 every second or third day, and then we keep on monitoring the liver functions. Some people would like to start rifampicin first, followed by INH. Some people start INH followed by rifampicin. In case patient has had the liver disease earlier, then they say pyrazinamide may not be given again. But in case it's a young patient who is well tolerating the INH rifampicin introduction, there is no high risk factor like alcoholic liver disease, malnutrition, and the other factors which are there with the liver injury. In that case, pyrazinamide can also be given, and then we withdraw the streptomycin and quinolone. Sometimes we see that people keep on giving quinolone in these cases, which is not required. So we should, in these cases, as patient tolerates all the 4 first-line drugs, we should withdraw the streptomycin and the quinolones, so that unnecessarily they are not given to the patient. And as we know, the 4-drug regimen is quite okay with these patients. So that's how we should manage the hepatitis, and we keep on monitoring the liver functions.
May I come in?
Sure, sir, please.
Thank you, Rupak, once again. You have just beautifully described how the TB should be managed in case of a liver problem. And one more thing I wanted to add, suppose, as you see, the sequence of adding the drug differ. You know, there are 2 types of thinking. One is the ATS guideline, another is a British guideline. We follow usually Britishers. So ATS says that rifampicin should be started first and then INH and other drugs. But British says no, isoniazid should be into. And we have seen in India that isoniazid, though in the Western literature, it is very, culprit for hepatitis. But in Indian, what I have treated, Indians tolerate very well the isoniazid. So what is, I also do that when reintroducing the drug, INH, rifampicin, and followed by pyrazinamide, if depending upon the case. One more point I would like to raise. Suppose patient is not able to tolerate, he has tolerated up to INH, ethambutol, or even to fluoroquinolone, and he has not tolerated rifampicin and pyrazinamide, then the duration also has to be kept in mind. Then this regimen would never be called as a short-term chemotherapy. This would become a usual treatment, a long-term in our time, we used to say. So at least 1 year of therapy, if the rifampicin and if pyrazinamide is not tolerated, the treatment will go minimum of 9 months. And if rifampicin and pyrazinamide both are not tolerated, we are depending on INH, ethambutol, or fluoroquinolone, then the minimum duration, what I believe, is not less than 1 year. That is also has to be kept in mind while treating such type of patient. Thank you.
Thank you, sir. Thank you for that addition of these comments. So as sir said, in case PZA cannot be given, we go back to the famous BTA trial, wherein they had given 2 to 3 months of INH, rifampicin, ethambutol, followed by INH and rifampicin for about 6 to 7 months. And in case the rifampicin, pyrazinamide both are not tolerated, then it goes to SHE for about at least a year, depending on the response to the treatment. One more thing which I would like to add is that one protocol is you add the drug one by one, low dose, higher dose, next higher dose, normal dose. Second, one protocol which has also been tried is that you start all the drugs together. One. Second is, the third protocol is you start with full dosage of INH, followed by full dosage of rifampicin, followed by, if you can introduce, full dose of pyrazinamide. So all the three protocols have been tried, and there are articles on this that they are equally effective. But the usual practice across the world is we introduce drug one by one in lower dosage, then higher, and then the normal dose, something like that. But we should be aware that these two protocols of giving all the drugs together in full dosages, or full dosage one drug, then full dosage second drug, full dosage third. Thank you.
Thank you, Dr. Singla. Dr. Sangeeta, sorry to keep you waiting. Dr. Sangeeta is a senior pediatrician, head of the department for pediatrics at NITRD. Yes, Dr. Sangeeta? You are muted. Dr. Sangeeta, you are muted.
Still muted.
Ma'am, you are muted. We cannot hear you.
We can give you access.
Ma'am, you are still muted. We are not able to hear you. Ma'am, we can't hear you. Dr. There's a question. Meanwhile, we'll take that till this technical glitch is sorted.
This is basically on the intolerance to the ATT. Suppose the patient is intolerant to ethambutol and we are giving HRZ as a regimen for the patient for drug sensitive TB, and he's also intolerant to levoflox. Then what else should be given in CPPs?
You see, all these kinds of permutation combination we have seen, and let me tell you, we have had patient who had skin reaction to most of the drugs, patient of proven drug sensitive. We even had to resort to the second line drugs. However, in the case which is being discussed is in case ethambutol is not being tolerated. So you see, this was the regimen earlier in countries where the INH resistance is low. Even the regimen of 3 drugs, INH, rifampicin, pyrazinamide for 2 months, followed by INH and rifampicin for 4 months. So that can do. So in this case, especially we should try to rule out INH resistance by the first hand LPA. And in case you find the INH is sensitive, even 6 months trial of HRZ followed by HR, it may be sufficient. But in case we find no, it is resistant or likely to be resistant, we can't rule out INH resistance, and even the quinolone cannot be given, we should try for the injections, injectable streptomycin or amikacin. In case even that cannot be given or the patient refuses to take the injections, we have to resort to the second line drugs. It may be linezolid, maybe clofazimine, maybe cycloserine. Bedaquiline usually is not being given in such scenarios. But I think gradually as the things will evolve, bedaquiline will be treated as one of the second line drugs belonging to group A, and people will agree that in such scenarios, even bedaquiline can be offered to the patients. Thank you.
Thank you, Dr. Singla. We are not able to. Sorry, sir.
To manage, actually, one more sentence I would like to add. When you are managing a case of TB with lot of drug intolerance, now every rules maybe you may not be able to follow. So minimum number of drugs, as Rupak said very rightly, we see lot of cases with drug rashes, where it is very difficult to start all the drug. So in this scenario, what is my advice and what I do is what the bare minimum number of drug patient can tolerate, and ultimately he is responding to it also. That is the way I take and usually should be taken. But there one more thing, that then the duration of the treatment may have to be little prolonged. You may not follow every rule of treatment there. Then the duration sometimes to in best health of the patient, in the best interest of the patient. Sometimes what we do, we will little prolong the treatment so that patient remains final outcome remains good. Thank you.
Thank you so much, sir. If are there any questions or comments? Since we don't have any comments, I would just like to say that what I have learned from this case is that talking of nephritis or hepatitis, we need to sensitize our staff at the ground level as to recognize these symptoms, whichever ADR is happening. We have to give them some basic training to recognize these ADRs as quickly as possible and refer to the higher center. And when they come to the higher center, we should have the ready protocols as to how to go about managing these ADRs. And the other thing is, for this patient, we just need to keep in mind that we need to do initial the LPAs and the liquid cultures for that. So the universal DST is the rule which we all should be following. So with that, I would like to wind up. Dr. Padma, you wanted to say something?
No, this was just a suggestion because we should also be monitoring adverse events for even drug sensitivity. This ADSM, now we think ADSM is only for drug resistant or new drugs. I think we should also have some mechanism to monitor drug adverse events for drug sensitive TB patients.
I agree with Padma, Nita.
Yes,
I
sir.
agree with Padma because what we see in the program, drug intolerance is one of the thing which is not, I mean, what word I can use? Probably more and more things has to be done on, because many of the patients, such type of patients who, although drug intolerance is not very common, serious one, and they should be followed, and some should be that they should complete the therapy. Because many of the, the loss to follow up and changing of the doctor, they do happen when there is a problem of drug intolerance. So I usually say and to my students that whenever you prescribe anti-TB drug, you must sensitize your patient, must counsel your patient about the drug intolerances. What are the adverse drug reactions you may face? You have not to fear the patient, but you have to tell them and tell them that if you develop such type of thing during the course of treatment, you must come to us. Don't go here and there. Because other doctor, it will be difficult to understand. Person from where you are taking the treatment, or clinic from where you are taking the treatment, you must go. And then the staff also, I agree, has to be sensitized about the various adverse drug reaction and what is to be done for those adverse drug reactions. So that's I think one of the very important steps to improve the outcome in NTEP. Further improve the outcome of NTEP.
May I come in?
Thank you.
You see, through this forum, I would also like to inform that we wish to thank Dr. Padma that she is offering the services of therapeutic drug monitoring. You see, as a referral institute, we get many cases who have been taking the drugs regularly in proper dosages. They are of good quality, and still they are not responding to treatment, and they continue to be drug sensitive. Whenever the testing is done repeatedly by gene expert, by LPA, by midget culture, we find they are sensitive. So these are the cases we consider that they should be subjected to therapeutic drug monitoring. And Dr. Padma and her institute NIRT is supporting us on this. We collect the samples from here. There is a defined protocol for this. and then in cold chain we send it to the NIRT Chennai, and we are also getting reports on time. So I would like to thank Dr. Padma for supporting the national program for these kind of services. At the same time, I would like to request the Central TB Division and the DDG TB that we need more such centers in the public sector who can offer this kind of facility free of cost. Thank you.
Thank you.
May I say something,
Thank you,
sir?
Singla sir. I totally agree, sir. We need more centers. We are open to training if people are interested. All they would require is one HPLC mission and dedicated staff. We can even train NRLs, IRLs. We also discussed this with both DDG TB and Dr. Nishant. People are willing to learn. We are willing to train them, and they can take it up also.
Thank you. Thank you, Dr. Padma.
May I say something, ma'am?
Sure.
Yes.
After differentiated TB care is being rolled out, in which all the diagnosed patients are tested for hemoglobin and for other symptoms also, temperature, pulse, edema. So at the baseline and every month also. So with this, all the CHOs, they are doing it, and to find any early symptoms. So it's there in the program. By strictly following this, we can identify the disease at an early stage and take proper action accordingly.
Yeah, thank you, sir. Thank you for your comments. So with this, we wind up today's clinic, and now I request the NTF chairman, sir, Dr. Ashok Bharadwaj, to give his final comments.
So thank you, Nita. So first of all, I must congratulate Dr. Reddy and his team. So for discussing the history of this case in total detail. They did not hide anything. They revealed everything which they have done for this case. My one query was, the patient was diagnosed with ATD like at least 15 year or 10 year back, and then the case came again to them. But what happened in between? Because patient used to visit private practitioner also, and what was given there, we don't know. So this is one issue. The next is, as told by Dr. Padma, so we are not giving due importance to ADRs. Whether it is DRTV, of course we are giving something for DRTV, but for DSTV we are not thinking at all. So we must give weightage, and at least UDST has to come in. While managing the case, such type of case, we must not compromise on the national guidelines. We must follow the guidelines, and if there is some integrities between that, so we have person like Rupak Singla who are one phone call away. There are other national experts like Rajinder Prasad, Dr. Behra, who can be contacted by telephone if there is any problem in managing such cases. So, but we must not compromise on the national guidelines. So UDST has to be done, and if for some reason or other the lab is temporarily not functioning, we must avail, as Padma told, we must avail other opportunity to send the sample to the nearest lab. So patient care is the first priority to us, and we must avail all the opportunity so that we have the result of UDST. So thank you, Dr. Nita. Thank you, Dr. Singla, for taking this national TB clinic to a new heights. So the people from Bangladesh, they are also attending these. So hopefully we will move to another height. So thank you very much. Thank you, Nita. Thank you, Rupak. Thank you, Rajinder Prasad ji. Thank you, Dr. Padma, and all who are attended. So one I want also to add from Gunjam, the MODTC from Gunjam. Yes, differentiated TB care model has been started. They started from the Chennai. The NI undertook a project on a project mode. Then they started in Karnataka. In many states, they have come up with the differential TB care. Hopefully, because this was taken to reduce the mortality due to tuberculosis. So hopefully, the whole country will go in for differential TB care model, and we will reduce the mortality due to tuberculosis. So thank you very much. Thank you all.
Thank you.
Yeah.
Thank you, sir.
Thank you so much, sir. With this, we end our clinic, and I would request you all to please give your feedback. There's a link in your chat section. Kindly give your feedback in the link. It really helps us. So we look forward to your feedback. Thank you so much. Thank you.